Welcome to the Reviewing the CMS Form R-131, also known as the Advanced Beneficiary Notice of Non-Coverage webinar. The Advanced Beneficiary Notice of Non-Coverage acronym is ABN. Most of you may be familiar with the term ABN. Some of you may be familiar with the full title, Advanced Beneficiary Notice of Non-Coverage. Typically during this webinar, I do use the acronym a lot, so ABN. I am Tom Ryan with WPS Provider Outreach and Education. I'll be your presenter. Today, I'm joined by Ashley from my team, who's going to help me with questions and putting some different information into the chat for you. So we want to make sure you're well aware of what you're here for. I will let you know that I did get a couple of questions about Medicare Advantage plans and whether the ABN is used for them, and the answer is no. This is a fee for service or a Part A and B form. We'll talk more about that as we get going here. Couple of things. If you would like this presentation, it is available for you to download right now. It's on our training center. Gonna have Ashley put the link to the live events page on our website, and that way you can go ahead and download it. Now it is the presentation. I will also let you know that once we remove this from the training center, could live events page, which again, the training center live events, will either be later today, maybe tomorrow morning, not sure exactly when it's going to be removed. It will then be put back up on the Encore presentation page, but that can take a week to 2 weeks to get done, and then will remain there for 60 to 90 days. If you have questions, we will take them in chat. We're not going to try to open the multiple lines and have you all speak and do all of that. What we found is that the chat actually does work better. Ashley will read those questions out to me a little bit later on, and we'll get back to those. Last, there's going to be a survey given to you. I do want to encourage you to take the survey. It's given at the end, and there'll be a variety of methods to do that. The survey is very important to give us the good, the bad, and the ugly. The good, what did I do well? What does WPS do well? Because you will be asked to rate us on an overall MAC. The bad, what did I do bad? Did I speak too fast? Did you not like the information? Did I miss your question? Any of that. But remember, you can also put questions in the chat. Also, the ugly is just simply the PowerPoint. Did you like what I showed you? Did you like the PowerPoint? Were there other things that may have been more beneficial? With that said, I'm going to go ahead and move on to the disclaimer. Remember, this is material to assist you in education. Luckily, the CMS instructions for the Advanced Beneficiary Notice of Non-Coverage, or ABN, haven't changed in a while. I will let you know that the form is coming up for review, sorry. So it's coming up for review, and we'll talk more about that in a little while. But the current form, I'll give you all of that information as well. So that's where we come with the Medicare rules change often. If there are rule changes, you do want to use the official website, which is CMS's website, or cms.gov. We do offer guidance on our website, and we'll link to CMS's website frequently. I'm going to give you answers based on what you gave me for facts and questions as I understood them. Now, that is part of this presentation, and they are built in. A big part of this presentation is those questions and answers, and we really do want to address or help you through that problem. Whatever you're facing, we want to make sure you get what you need. Oops. So our goal to provide answers to the questions regarding the ABN. One of the base questions did ask me to explain the ABN and to kind of go over the form. So we'll start there when we get that far, which is the first bullet point. And I was asked again, where is the form located? How do I even, get this form? I think these are some people that really aren't familiar with the ABN. Maybe they don't use it on a regular basis. There was also, I will tell you, some people that were brand new to Medicare. They stated that. And so they just need some basic information. I don't want to leave them behind, which is why some of this may be a review for others. The last portion is, again, to focus on the questions that you pre-submitted. Those are built into the slides with a couple of exceptions because they came in a little bit later than I needed to get the slide deck ready, followed by chat questions. Okay. I may use the term CMS-R-131 and ABN also just interchangeably. It is the same thing. The form number is the CMS-R-131. The title is the Advanced Beneficiary Notice of Non-Coverage, and the acronym is ABN, all interchangeable. But again, if you have questions or you need a reminder of what I'm talking about, please put that back into chat. That would include if there's an acronym that you don't know. So let's start off just explaining the form. What is the purpose of the form? Why should you use the form? And why is it important in the overall? So the form, again, has the term advance. So we want to make sure that you are aware that it must be given in advance. That's part of the purpose. It is also an Office of Medicare Budget approved form, which means it is a CMS required form, and there is no exceptions. You have to use this form. But what is the purpose? The purpose of this form is to help make an informed medical decision by the patient. That medical decision is when a service will be deemed not medically necessary by Medicare. Basically, that medical service is not under that diagnosis. It's not a covered diagnosis for that Medicare today for that patient. That's when we want to use this. We want to tell the patient, hey, this isn't medically necessary for you today. So therefore, we're going to bill it and it's going to be your liability. And we'll talk more about that in just a moment because it does involve some modifiers only to add to the claim. Now, it is going to convey to the patient that they are likely to provide a coverage in a specific case or not covered service in a specific case. And I want you to notice coverage, medically necessary coverage, that's not going to happen, or not covered being never covered by Medicare. And we'll talk more about the difference there because it is very different. So let's move on to the first one, which is medical necessity. So Medicare medical necessity. This means the patient will know before the service that Medicare may deem this service as not medically necessary and they are responsible for that service should that happen. So if you inform them, then the medical necessity is then then the service that is not medically necessary, deemed not medically necessary by Medicare, becomes the patient's responsibility. Well, that leads you to ask me the question, how do I know what services are medically necessary? How do I know? First, I'm going to tell you research the National Coverage Determination NCDs or the Local Coverage Determination LCDs. If there isn't policy covering it, there's normally an article that goes with it, and the article gives you diagnosis codes. Now, not everyone does have it, and sometimes you do have to read through the policies for the indications of coverage and figure out when it could potentially be not medically necessary. But again, the policies are national coverage determinations as written by CMS and local coverage determinations as written by your Medicare administrative contractor, in this case, WPS. Okay. Local coverage determinations are not across the nation. They are specific to the contractor, as I said, which means for WPS, they cover jurisdiction 8, Indiana and Michigan, and jurisdiction 5, Iowa, Kansas, Missouri, Nebraska, and our providers across the rest of the nation. There is also something called manuals. Some people have heard these referred to as the internet-only manuals, the IOMs. These are all the manuals. They're available on the CMS website, and in many cases are the day-to-day operating instructions for Medicare. There is a benefit policy manual, and we're going to look at that in just a little while, but there is a benefit policy manual. So that's where you get some of the information. There's also things for preventive services, and we'll talk more about some of those different pieces, but they're within the manuals. Should there not be a manual reference or a policy, then what actual drives this is the patient's documented condition. What's in the documentation to show that this patient needed this service by this type of a provider today. So that's when the Medicare medical training comes into play. So what is this provider trained on? What are they determining this on? What are they looking for within that medical record today? One of our clinicians loves to use the term "not for Fred today" when describing a medical necessity denial. What she is saying is that that if the same patient had a different diagnosis, then Medicare would cover the service. Or if the same patient was seen for a different reason, was seen by a different provider, this may be a covered service. Somebody did ask the question, when I say different provider, what does that mean? Let's keep it as simple as possible, but let me use an example. A podiatrist cannot see someone for a heart issue. It's outside their scope of practice. It's not within their license. So we do have to use state licensure to determine that. So the service can be perfectly medically necessary, but not within the scope of practice of that provider. So there's a variety of things. And we'll talk more about that because there's mandatory and non-mandatory uses. Also, as I said earlier, I want to remind you that this is for traditional Medicare. Traditional Medicare is Part A and B. Now, an ABN is not used for inpatient services, which is a Part B defined service. There are some other forms that you would use for that, but this one is not. This one is for outpatient services, professional services, and supplier services under Part B, which again is exactly what I just defined. However, someone asked, could a Part C plan require this form? According to CMS, they should not be requiring this form, though they could have something similar that they want you to use. They could reference you back to the directions for this form in order to use their form, or a variety of other things can happen. So I don't want to say they never can use it or they're never going to be able to reference it. The basic gist of it is this form, though, is for traditional Medicare Part B services. Okay. Are there standards? As I said, yes, there are standards for this form. This form is approved by the Office of Management and Budget, OMB. It's reviewed approximately every 5 years. That's part of the federal standard. It's not anything to do with CMS or the Department of Health and Human Services. It's part of the overall guidelines. Now, as a reminder, this form is currently dated with 2026. So we know it's coming up for review, and CMS will let you know when it does change. They'll use their website, they'll send out an email, they'll have us send out an email letting you know that the new form's available, if there's a transition period or whatever is going on with that, okay? There are some key items you need to know when you're looking at the standards. One, you can reproduce this form. That means you can make your own version, and there are certain things that you can change, but for the most part, you don't want to make major changes, and we'll get into those in just a little while. Now, what this does is allows you to make some areas have checkboxes. For instance, Medicare never covers this service. Medicare does not cover your service today for your diagnosis. Those are types of things you could add as a checkbox. But you want to make it sure or clear that that is given information to the patient. And we'll talk more about the delivery option and the presentation portion in just a few moments. This is one form on one piece of paper. In other words, you'll make it so long that you start having multiple pieces of paper. If you said, hey, I added some checkboxes and therefore it went from the standard piece of paper to a legal size, that's okay, so long as you're not changing or adjusting a lot of other things. One of the other issues that has come up is that it's not on a black and white piece of paper. And so that comes up with low visual acuity patients not being able to see or understand the form. They're completely reliant upon you. So CMS says it's best to use black and white, or black paper with white. Sorry, let's try this again. White paper with black writing. So again, keep in mind, we want to use white paper and black writing. That's going to give you the best visual contrast for what the patient needs. I did just mention that there are minimal changes that are allowed, and I'll show you an example of one in just a few moments when we talk about completing the form. But for those of you that are familiar, there's a D period with a line which you insert a word such as service, item, something like that. You can remove the D period in the line. That's just an example. That's a minimal change. It's allowed. It actually might help the patient make more sense out of it. Could you remove a line that separates the top, the header, and the body of the information? Sure. That's not going to invalidate or make it that much different. So minimal changes, but we'll talk more about that when we actually show the form. There is a requirement that you must maintain this form for 5 years from the date of discharge or delivery of care. So 5 years. This may be different than your standard form. The reason that we put, different than your standard retention dates, because your standard retention date from your state may be 7 years or 10 years. If it is longer, you must follow your state retention date versus the Medicare one. Okay. So that's just some basics of the standards. Let's go through some delivery options. And the reason that we choose this to do this is we did have a question about what other options if we are a provider who doesn't see the patient. Now, the types of providers that would not see a patient but still may need this form, labs. You don't see the patient at all, but you still may need to give this form because the service you're providing, the actual running of the lab is not covered. So let's talk a little bit about some of these delivery options. So first, it is always recommended that you give this form inpatient, that you explain it, that you're adding information to all parts of the form, and that everything is done. It is also recommended that if you are a lab or someone else that is reliant upon another provider to give the part of the service. So for instance, you're a lab, you don't see the patient because you don't do the blood draw, so you're the reference lab. The doctor's office or whoever did that blood draw can actually add you onto the form and explain for that purpose. We'll talk more about that. You can make contact via phone, fax, email, or mail. What your goal is, if you make contact, is to document it. Okay, contacted them via phone, here we go. However, you do have to do a follow-up with the form or a copy of the form where you're requesting the signature. And you want to document that you've done that follow-up, a couple of different times, making sure that you're trying to get what you need to get back from the patient. The patient may not be responsive, but if you've documented that you at least did your attempts, there isn't much you can do other than that. Okay, so please also note that CMS does use the word attempts with an S, which indicates more than one. Because of that, we don't say, hey, it's 1, 2, 3, or 27 attempts. What we do is we say, well, you need at least more than one documented, and it's how many ever you feel comfortable with or whatever works best for your practice. One thing that does come up is that you must be able to explain the completed form. What does that mean? That means that no matter what method you're using, the patient must be able to ask questions. So if you're mailing it to them or you're emailing it to them, give them a number to contact you so that you can explain this. You're presenting the form. If the patient doesn't want an explanation, they don't have to call you back. Key things with explaining the form. One, it has to be complete. You must not add additional information, change information, do any of that once you've explained or once you start explaining the form. Now we'll talk about those exceptions because of course there's going to be exceptions. Once the form has been explained and presented, then you cannot make changes, again, with a few exceptions, and we'll talk about a couple of those. They're going to be in the comment questions because they're things you guys asked. You may note anything on the original form that you need to note. That's fine, but please make it so that you can see or that it stands out as an addendum or a note or some kind of indication that it's new, that it's different, that it wasn't on there originally, okay? You must present the form in a manner that allows the patient to ask questions of the presenter in a manner they will understand the response for. Someone asked me if the provider themselves could do this. Could they present the form? And the answer is sure they could. But please take time to listen to what they say and how they say it. How many of you have a doctor that when they go to present the form, they talk very high technical terms, and even sometimes the nurse has to kind of help remind them that maybe this isn't a medical professional, okay? If that's the case, then that's what you want to look at first. Are they able to answer the patient's questions when presenting the form? If you have questions that come up, you must allow the patient time, that come up and you cannot answer. You must allow the patient time to contact Medicare. That is done through 1-800-MEDICARE. They'll call Medicare, they can ask whatever questions they need to, they get whatever answers they need, and hopefully then we can move forward. There are always two copies. One is the copy that the patient has signed, which is the original, and you keep that one. The second one is a copy you give to the patient. second one is a copy you give to the patient. So that's where we're at with some of those basic pieces of information. The form is located on the CMS website. These bullet points just will give you the path, which I'm going to use right now to actually show you where it's at, but I'm going to go to the website to do that versus trying to use this slide. So we come to the CMS website, and this CMS website is cms.gov. We go to Medicare. Then you can look through and you can see a bunch of different items here, okay? What we're looking for underneath here is forms and notices. And you can, sorry if I scrolled too fast for you, but it's just towards the bottom. So scroll down. There's the Beneficiary Notice Initiative. This is part of that initiative. Remember I said there's inpatient and outpatient forms. This is going to be an outpatient form, but it's under the Beneficiary Notices Initiative. When we look at that, you can go to the fee-for-service ABN to get more information, because that's what we're talking about. This is the CMS-R-131. Or you can simply scroll down and then there's a chart. I do like the chart. I think it's a great thing to look at. One of the reasons I like the chart is it's really easy to open the PDF document, which is your form instructions, or to unzip the file. I've already unzipped this, so I've downloaded it and done all of that. But here's the form instructions, and this is what we're going to walk through in just the next couple of pieces of information. And the file actually looks like this. So there's the different things where we said, oh, you can't really make any major changes, but I did say, hey, if you leave this line off, which is right below the header information, that's okay. Or if you take the D out with the period in the line, that's okay. Those are the types of changes that you can make. Those are the types of changes that you can make. So, all right. So hopefully you've now seen where you can get the form. Again, I want to go back to the CMS website for just a moment. You can read through all these form instructions, including this little one, which just talks about all the changes. It's every 3 years, all that. Here is the actual headers, what you need to put into each field, and we're going to follow through on a couple of these. But I do want to point out this one that says blank that I said you can take the D period and the blank off. Here's a list of verbiages. You can put item, service, lab test, procedure, care, or equipment. I know I read that very fast, but they are all in the instructions. And you want to make them match throughout so that everything flows smoothly and the patient is not confused about all of these different items or services, okay? So we'll get a little bit more into this as we go through, but one of the questions that we want to make sure you are aware of is how do you know which form you should be using and what version? And if you go to the very bottom of the actual form, you can see this one has an expiration date of 1/31/26. Yes, I understand that's coming up fairly quickly. This is, again, an Office of Management and Budget right here. So it's going to give you a form number and it's going to give you the CMS form number. They will review this. If they don't review it by 1/31, we'll just continue to use this form until CMS tells us not to. They'll usually give you a good transition date. So that's the form itself. All right, I'm going to go through the next section of slides, which brings us to the common questions. Now, these are questions that you asked or that are common, things we receive quite often. The first one is actually a question that I was asked, and it's what's the best method to determine the estimate? So here's going to be your answer, but I'm going to go ahead and show you where I got this answer, and then we're going to talk through it. So when I come back to this, you can see I already have this set up for myself. The estimates, CMS says it has to be within $100 or 25% of the actual cost, whichever is greater. However, an estimate that exceeds the actual cost substantially would generally still be acceptable since the beneficiary would not be harmed. So what does all of that mean? To start with, what would you charge a patient, someone who does not have Medicare, does not have insurance, does not have anything going on like that? There's no contractual write-offs from any other types of insurance. That's your base estimate. That's what you're going to charge this patient if Medicare says, nope, not covered. They do then allow some flexibility, and the $100 or 25%, whichever is greater. The reason that they allow that is what if a service has a spectrum or an estimate amount where it could be $25 or $75, and that's really based on the service, the procedure code build, all of that, which you don't really know until you get in there and you're meeting with the patient. Hopefully that makes sense. The final aspect says go high, not low. Well, that makes sense too. If I'm expecting a bill for $1,000 and it comes in at 500, I'm not likely to question why I didn't get charged 1,000. I'm likely just to pay the 500. But put it in the opposite direction. If I'm expecting a bill for 500 and I get charged 1,000, now I'm starting to question. Now I'm starting to do that. That's what the final statement says. So when you're looking at these particular items, I just want you to be aware of where they're coming from with that. The next item is if we go up a little bit, we see the reason Medicare may not pay. So that's going to be your next slide. And I'm not going to go back to the slide. I'm just going to keep going on. I'm sorry, it's the description looks like it's next. What needs to be contained in that description field? Well, remember there's two portions of the description because the description is actually D. So you're going to have a blank and then that would be one portion of it. And then you're also going to have a chart portion. Let me show you that so you understand what I'm talking about. This is the description field with a blank. This has to have the specific word. This is the description field as well, but this is your chart. This should describe the service in such a manner that the patient understands what it is. Moving on to that, you may have the reason Medicare may not pay, and this description should tell them what's going on with this service. In other words, Medicare may not pay today because this is not a covered diagnosis. That's a medical necessity thing. Medicare doesn't pay for this diagnosis. It could also say Medicare never pays for this service, it's just not a payment option. And when we have that happen, then it's only a portion of the form that needs to be filled out. If Medicare never pays for a service, then you stop after the estimate. You don't do the bottom parts down here. If it is the other option that I gave you, Medicare does not pay for this service today due to the diagnosis, that's a medical necessity, then you do need to continue down and fill out the rest of the form. Frequency limitations do fall under the same thing as a medical necessity, so yes, I need the entire form filled out. Hopefully that makes sense for these two descriptions and what we're looking for there. So again, description, what it is, how to make sense of it. Please don't put procedure codes here. Like we actually had someone do that and that didn't mean anything to the patient, to most patients. Now, if you have a medical professional who does coding, that may very well mean something to them, but Medicare just says don't do it. And then this is your reason that Medicare won't pay for whatever this service is here. Okay. Can I use this form, this ABN, for when Medicare does not cover a service? Okay, so let's talk about that. And again, we're on slide 16. Yes, you can. CMS does say this is what is referred to as an optional use. Optional use. So if that happens, how do you determine that Medicare never covers a service? You just know it in the top of your head? No, we'd actually like you to take a minute, come back to the CMS website. I'm gonna go ahead and just leave this for a moment. When we come up to the top, we want to go to Medicare, regulations and guidance, and manuals. Where I'm going here is the internet only manuals or the day-to-day operating instructions. And the reason that I'm going there is I'll show you in just a moment, is that it does contain a list of never covered services. So internet only manuals right here. Then we come in and we're talking about general benefit policy. Okay. Remember, if it's in general benefit policy, this will just explain a lot about the different benefits and coverage. Anything against any of this would be used until you would use the ABN until you get to chapter 16, because chapter 16 says these are never part of the Medicare program. Anything listed in here, follow the criteria, they're not part of the Medicare program. A little bit different. The other area that you want to make sure you look at is this National Coverage Determination Manual. And there's a variety of ways you can do this. If you say, hey, I want to use the Medicare coverage database, that's okay too, but it's going to give you the same information. When you look with it, the National Coverage Determination Manual, you can see it's got all of these different parts and sections, but if you open, I'm just going to open part 1, it'll actually walk you through some of the different policies that you may be need to be aware of. Okay. So if it's on the policy list, yes, you need to use it. If it's in the other, the benefit policy manual and that chapter that we showed you, no, you don't need to use it, and that's chapter 16. So it really depends on where you're going to find this service. If you say to me, I didn't find it anywhere, but now I'm going to come out here and I'm going to go back to the WPS website and I'm going to put it here. And I'm going to say, okay, let's use procedure code 99213, and what policies are that in? It will actually indicate to you, well, we don't have a policy for that E&M code. It will actually indicate to you what policies they're found in. So there's a variety of things you can do with this. We're going to use this in just a little bit more, a little bit later. So hopefully that makes sense to everyone. And again, I want to remind you, just as we were talking about this, when you do it for a non-covered reason, it is A through F that you need to complete. A through F. The remainder of this does not need to be completed. Does not need to be completed. Okay, let's move on to signature, which is down on the bottom of the form, and you can see it's in I, and I will also include J because that's the date. What happens if the patient can't sign this form? Well, there are other people that can sign for them. But what happens if the patient's, and other people could be a representative from a family member, a legal representative. So yes, there's a variety of can. Remember that that representative is not signing that they're taking over financial responsibility. What this actual signature does is says that, hey, I informed you of this. I gave you the form and I made sure you understood it. That's what the signature says. So therefore, they're not taking financial responsibility. Here's the date that goes with the form. The question, can you annotate the date? Yes, if the patient requests that you put a date on here, please feel free to do that and then put date by patient request. And we're good. So we're not saying the patient absolutely has to date it, but we are saying it has to have a date on it. Okay. Let's continue on the next slide, which is slide 19. And what happens when the patient refuses to sign the service? Do you continue the service? Do you note it on this form? What do we do? Now, if the patient, well, the first item CMS says is you should continue, or you should consider not providing the service. Why would that be? Because according to Medicare, this isn't medically necessary. Now, there are times when the provider will disagree with that and say, no, we need this service done. Or the patient will disagree with that and say, no, we want this service. In that case, what you will do on this form somewhere, I usually recommend using H in this additional information area just because it's a nice empty block, but you don't have to do it there. On the form, indicate who refused. Was it the patient? Was it the patient and their spouse? Whatever you need to do. Give us a refusal date. Just like this date down here, we want to make sure we have a refusal date. Also, whoever the presenter was that they refused to sign it for, have them sign the form. Have them sign the form. The last thing that we always encourage you, and I'm going to say we being WPS encourages you to do, not a requirement, is to have a witness sign the witness refuse it, refuse the signature, and then annotate who that witness is on this form as well and have them sign it. That is in case legally the patient comes back and says, I don't know what they're talking about. They never gave us that form. We now have another person as a witness as to who it is. I was asked if it has to be a medical professional. No, it does not have to be a medical professional, but I'm not really sure what you were timing or saying as a medical professional. I don't really know where you're going with that. So could it be your front desk staff? Sure. It could be pretty much anyone. The witness does not need to understand the entire form. They don't need to know about the entire form. What they need to hear is, no, I'm not willing to sign that, or no, we're not willing to sign that. So if you want more about that, let me know what you mean by medical professional. I might be able to answer a little bit better for you. Okay, the next slide, which should be 20, says how far in advance can an ABN be completed prior to a service? Medicare doesn't say it has to be completed in a certain time frame before the service. And I think that came from what happens if unexpectedly the patient cancels, but then they come in X amount of time later or whatever the situation is. So Medicare doesn't state that. So timing in advance is just that it is completed in advance of the service. It is given to the patient and explained. Okay? Now you also do want to make sure that if you're giving this and you discover that it's not medically necessary, so if you're giving the service, you're starting the service, and all of a sudden you're like, this isn't medically necessary, you can stop the service, give the form, explain the form, allow the patient to call 1-800-MEDICARE if need be. So there's a variety of things that can happen with that. One of the questions that we did get is for repeat services. And I'm just going to go ahead and catch my slides up at this point. I think we're going to be on slide 21. Yep. Does Medicare have a special rule for repeat services? And I'm not really sure what special rule you mean by this. So there isn't a frequency. Like there used to be, it was only valid for 1 year. That period of time was lifted. However, what Medicare does state is that there needs to be some indication that this is a repeat service. So in the description area, you may say Medicare allows 2 of these services per week. You're getting 3, or your provider said that 2 of these physical therapy sessions are medically necessary per week, but you're insisting on 3. The third one, that would be your responsibility. That's what you're trying to do. Give us the information so that we can look at what that means. We do recommend giving this form a few weeks before the start of service or a series of services. That's always going to be a recommendation. While you can stop the service should you discover it's not your best practice. Interrupted services, and this is what I was just talking about. I just discovered my service will not meet medical necessity. What do I do? CMS does indicate that you should pause the service, complete the form, give it out, have them fill it out, go through the full explanation. Okay. We were specifically asked for the modifiers, and so I broke it into 2 different sets because modifiers are done by medical necessity and not covered services. Now again, medically necessary modifiers mean that this service was not medically necessary for that today, which is the mandatory use of the ABN. So these modifiers are GA, which means that you have a signed and valid ABN on file. When you append modifier GA to a claim, it does not stop the claim from processing. It goes through every edit. It does not affect edit anything like medical necessity edits, any of that information. What it does is at the end, when we go to assign patient liability, we've determined it's not medically necessary. It looks at the patient liability and changes the assignment of liability from from provider responsibility to patient responsibility. That's all it does. So again, it's going through all the normal processing steps, doesn't get shortened, it doesn't do any of that. I always like to tell people the GZ modifier means I didn't give an ABN, so we're going to assign this to provider liability. Basically, it's the same thing that would happen should you not even put the GZ on there, because we're just going to consider the entire claim, get to that point where we would assign the liability, the contractual obligation CO versus the PR on the remittance advice. And what are we changing with that? Nothing. Therefore, it doesn't do that. So therefore, we call this one informational only. The GA has a function. It changes the liability. The GZ does not. So again, review your information, determine whether it meets the medical necessity and you have to give the ABN in advance, or was it not covered? Because there are 2 modifiers for not covered. One of them is GX, which does mean the service is still not covered, never a Medicare covered service. However, you did give an ABN to inform the patient that it was not covered. You did not complete the entire form. You stopped after F, gave them the information they needed, and went on. Are you required to give the ABN when it's not covered? And the answer is no. If you did not give the ABN, you're going to bill a GY. Now, I will tell you GX and GY do not let the claim go through the claims processing system fully. What does that mean? It means that these 2 modifiers stop the claim after the validity edits. A validity edit is something very simple. It means, hey, do we have the right Medicare number for the patient? Do we have the right provider number? Do we have the basic pieces of information that we need to process the claim? That's a validity edit. Once it hits there, if it has either one of these two modifiers, it will reject. It'll just stop. It's called a technical rejection. That technical rejection simply means Medicare doesn't cover this. It's not the same as a rejection saying fix it or do something else with it. It literally means Medicare will never cover it. These two do not affect patient responsibility because by definition, they are not services that are covered by Medicare. Okay? So they don't affect patient responsibility. Oops. There we go. Sorry, it flipped a little bit further than I wanted it to. Can a patient change their option for billing after receiving the bill? And the answer is yes, yes, they can. One of the things that happens is once they change that option, you must annotate this on the form. First, what option are they changing to? Now, I will point out the options just after I explain this. Second, who's the person requesting the change? Is it the patient? Is it an executor of an estate because the patient has passed away? What's going on? The date that they requested it. Also, though, note the bottom one, you do have to send it for a signature. For those of you that are not aware, look at the Medicare Claims Processing Manual, Chapter 30, which is the financial liability section, and you're going to check out, financial liability protection, and you're going to check out 50.6A1, which explains all the steps for this. Basically, it's exactly what I gave you. Once you note this change, you do have to forward a copy just like before, and what you're actually doing is taking that copy and you're sending it for a signature, just like when you gave it to them over the phone or whatever the situation is. So you're noting a change, you're sending it for a signature. This doesn't mean that you can't fix something or you can't adjust something or you can't do something like that. So I know I mentioned this section and it's a different section than I've previously shown you. So let me take a minute here and show you where that is. So we're going to go back to the CMS website. And it's going to be in the same place to get to these national coverage determinations. So back in the internet only manuals, except this one is in the Medicare Claims Processing Manual. By scrolling down, you'll come to chapter 30. And if you don't like the fast scroll, I apologize, look away. The financial liabilities protection area is chapter 30. When we open that, you'll see a variety of different pieces of information. And it talks a lot about things you need to know. But section 50 is all about the ABN. I'm not going to go through all the different parts of the ABN. I will tell you this is interesting information. It tells you when the ABN applies. In other words, mandatory use, and when the ABN is optional. And it's based in the Social Security Act and the different sections that are covered. Okay. But as we scroll down, we want to find 50.6. So we come down. Oh, and all the different changes and the modifications and what you have to put where, this is all done in this general notice section, which is 50.5C. So it kind of talks a little bit about some of that different pieces of information. But 50.6, completing the ABN, then if we keep going down a little bit more, what we're looking for is A, and then we're looking for 1. What happens if they change their minds? And that's where you're going to get that information from, what you need. So hopefully that makes sense to you. And how to find that piece of information. Before I open for chat questions, I just want to run through a few more that were pre-submitted that I'm not sure we've gone over, but I want to make sure we hit. The first item I have is, again, a reminder. The most current version of the form right now is 131-2026. No, we do not have information on when this version will be updated. Again, the OMB, which is the Office of Management and Budget, has to review the form, set it back to CMS if there's changes or whatever gets through it. So CMS will notify us when this is done. The next question is, when is it necessary to have the ABN signed? As I stated, it's necessary during the mandatory use, and it's not necessary during the optional use. Does Medicare never covered charges require an ABN? Never covered indicates to me that it is an optional use. In other words, it's just not part of the Medicare program. If that's not what you were talking about with those, please let me know. How to accurately explain the options, they need to select the patient to select for our elders. Sorry, how to accurately explain these options. Now, the options that I'm guessing you're talking about are these three right here in the middle. Okay, because option one says, I want the service, bill Medicare. Once Medicare determines, then you can bill me. Option two says, I will take the service, but I don't want you to bill Medicare, so you can bill me right now, today. And option three says, I don't even want the service, therefore you can't bill Medicare. Okay, that makes sense. The reason that a lot of people choose option one is this part right here. The patient can file an appeal should they disagree with the medical necessity and have Medicare look at it from that perspective. Now, in this case, usually Medicare will ask you for additional records or things like that. Even though the patient is filing the appeal, just know that it does happen. So how do you best explain these options? Just as I said, do you want Medicare billed? Yes or no? Do you want me to do you want to take the responsibility without having Medicare billed? Okay. Or this isn't medically necessary, therefore I don't even want the service. That's how it's best and easiest to explain. Please remember to keep your information as neutral as possible. You shouldn't be influencing their decision, but you should be able to explain what's going on with these three options. Is there a technical or super easy way to do this? My answer to you is not really. It's more up to you to decide what you're going to do and how you're going to explain it. Okay. So this one says that we get denials on basic lab panels and they never trigger an ABN in our system. Okay, so when you're doing a basic lab panel, what are you doing it for? Because that becomes part of the problem. Are you doing it for a medical necessity reason? Are you trying to do it to determine what lab or what's going on with this patient? In which case you may need to file an appeal to say, hey, it was medically necessary. We don't even understand what we're doing with this patient. Or are you doing it for a different purpose? So I can't answer whether you need an ABN or not for some of these because I don't know. I will tell you if there's no medical reason and you're just doing a lab, and it's maybe for an employment screening, travel out of the country, whatever that happens to be, then no, that's not covered, and yes, you need to give an ABN. Okay, so I'm not really sure what's going on with that one. If you want more information, you'll have to ask me. And then we have one that gives us specific procedure codes, and it's A2002 and a range of codes from 15271 to 15278. And this is about the outpatient prospective payment system, which absolutely could use the ABN. And then it says, hey, these are, says, can A2002, if billed with that range, be covered under OPS bundled payment fee schedule under WPS Medicare if a hospital outpatient center, or does a modifier have to be appended? I will tell you, if it is a bundled service, it is not something that goes necessarily with the ABN because the bundled service means it's included in another service. It's not something that you would give an ABN for. Bundled means paid, just not paid standalone. And can you append a modifier? I will tell you as of right now, you could. And the reason I say that is because it looks like in the future, we're going to have a policy, a local coverage determination that will limit this. How do I know that? Well, if I come out to our website, and I mentioned this earlier, this code lookup, if I put in the A2002 and I hit search, it comes up and says, look, you have something going on here. What do you want to do? Well, I actually want to look at it, right? So let's go ahead and look at it. Okay, right here, original effective date isn't until January 1st of 2026. That means that we don't have these audits and edits built in yet. And because of that, this is not in effect yet. It doesn't mean it's proper. It doesn't mean it's going to pay it. It could be bundling under the ops, which is again a bundled system, and it could say, no, we're not paying it under that. What we are going to find out is that the A2002 in the future, if we go to the billing article, will be an excluded service based on diagnosis, so it's never paid. I'm not really going to sit and look for this, so what I find out is the following are non-covered services, and there it is. Now, the reason that you have to be careful with just saying non-covered is it never covered, or is it covered by Medicare using a different procedure code? In other words, could you take this, move it into a different procedure code, and have it be covered by Medicare? So hopefully that answers that question. Again, it's a little bit weird because it is an upcoming one. It's not one that's currently active. With that, do we have any questions, Ashley?
Tom, we did have one question come into the chat. This one was, if there are 2 LCDs for one CPT code, how do you know which one to use to determine medical necessity requirements? And they give the example, hypoglossal nerve stimulator has LCD A57092 and A56953.
So it's really going to be in the indications and coverage, which gets a little bit more complicated, just so you know. But I'm just going to bring this, whoops, I forgot to type LCD, which is good. So A57, so this is not a code. Let's go here, all tools, and do the lookup this way. And the reason that I like doing that sometimes this way is it actually gives me the numbers and everything that I'm looking for. Because an A indicates that it's an article versus an LCD. You can see these L's are all here for you. And I'm just trying to see if I can find the associated LCD. Okay. So let's see that we do this and we say, okay, we've got the A57092. Let's take this off and see if we come up with nothing. Shoot. I don't see where that one is coming up at all. Let's try this. Again, I'm just searching through trying to find this code in general in the LCD or in an article, and I don't have anything coming up with that. The other way to do it would be to Google one of these. Okay, so billing and coding. Okay. Okay, so this isn't a WPS LCD. The one that you gave me is referencing something from NGS. You would have to ask NGS that question. It didn't sound real familiar to me. So this one is governed by NGS. Let's see what the other one that you gave me is, and that may be our answer. One may be an NGS LCD, which is not WPS, and one may be an and this one is First Coast. So neither one of these would apply to WPS. So unless there's something specific like, make this up, like italicized verbiage or anything, it wouldn't apply. On the other hand, if you're reading something like this and it's talking about the Social Security Act, you can go there and check out information. If you're scrolling down and there are documented references within it, and I was just looking to see if there were any, and I don't see any, those references very well could apply. Revenue codes, but the actual information within this does not. So here is where we're going to look for. There's no NCD. Oh, well, okay. So this one isn't going to be super helpful in that way, but sometimes it is. The other thing to do is to come back to the LCD, scroll down to the bottom of the LCD. Again, this is for any contractor. We aren't going to look at all the information within it because WPS isn't bound by that, but you could use any of the bibliography or source information. This is stuff that we can also use to help determine coverage. So hopefully that makes sense. But again, neither one of those apply to WPS. Any other questions?
We had one more question come in, which was, so if it's non-covered in the LCD, it would not need an ABN form?
No, actually, it's non-covered in the LCD due to a diagnosis code, so therefore it would need it to say this is not something that's covered today. The non-covered items that do not need the ABN form are in the internet-only manual. It's a little bit different there, so hopefully that makes sense to everybody. Any other questions?
That was our last question in the chat.
All right, well, then we're going to keep going here. Just as a reminder, we will send you an email shortly. The email will have your certificate of achievement, so please don't delete it. A couple of things. The certificate of achievement on the bottom does have contact hours. Those contact hours may be accepted by a governing body for CEUs, but we don't guarantee CEUs on any of our information. Someone did ask me about the AAPC and how that works because we're not listed as a vendor. However, Medicare and its contractors are. We are a contractor for Medicare. That's how we are listed. So we are not listed as WPS. So hopefully that makes a little bit of sense. Also want to point out in this email that you're going to receive Your Opinion Matters. This is just some feedback stuff we'd like you to take. We'll talk more about that in just a few moments. If you do not get the certificate because you called in, which means that you did not give us an email address, I can't send it to you, but you did call in, give me an email. Where are you going to email? It's the same thing as I would like your follow-up questions. You're just going to email this email address, WPS.GHA.education@WPSIC. You have 7 days to send those emails. What we're looking for is if you need a certificate, I need a phone number with area code to say, hey, I was on, we're good. And I need the certificate. If not, and you come up with a question in the next 7 days, we're more than willing to take those, but they have to be related to ABN. We did get some randomized questions in and those ones won't work. So make sure that we do that. We'll make sure you get us the information. Let's talk briefly about that survey. You're gonna get a link in the chat pretty quick here. Take the survey, please. You can do it in a variety of manners. One, you've seen it in the follow-up email that's gonna come out. Two, we've got a link in the chat so you could actually take it right now. Three, when I close the event, you will get a pop-up box. The pop-up box is not spam, it's not malicious, it's not anything like that. We'll have a little triangle, it's an external site, it's like the bottom picture. We'll have a destination, and that is actually us asking you to take our survey. If you select continue, it'll take you there. Now again, I want the survey so bad that even if you're taking this as an encore presentation, I'm going to give you a picture that's going to look like the online survey with the 5 stars. We just want to know that you want the survey. So what am I looking for on the survey? Number one, suggestions for education. Anything you want. Doesn't have to be related to ABN. Really just whatever you want. Number two, how did WPS do as an overall contractor? Number three, specific to this education, the good, the bad, and the ugly. What did I do well? What could I have improved on? And was my PowerPoint what you expected it to be? Did you find it useful? Any of those types of things. So that's what we're looking for there. We did want to let you know that we do hear you and we do make changes based on what you have. So we did add chapters to our YouTube channel and training indicators. Those are the 2 most recent changes from the survey, but we do make them. So if you ask us for something and there's something you like in that survey, we will consider it. We'll try to make those changes as quickly as possible. And that brings us to the end. Thanks for attending. We are glad that you joined us today. Remember to give us your feedback. Also remember, we really do want topics related or unrelated to ABN, doesn't matter, just whatever you'd like to hear in education. Don't forget to check out our live registration page for more information on what to register for. On behalf of myself, Ashley, all of Provider Outreach and Education and WPS as a whole, thanks for participating. We look forward to your survey comments and future education. You may now disconnect.